Start.
So common competencies is 7 questions. That's like 13% of the exam. And common competencies is like common sense. They are very easy to grab, but unfortunately, everybody gets low score in this. Therefore, we will revise common competencies today. I'm Sajjad Pathan, and we will be talking about the common competencies questions that are likely to appear in the forthcoming exams. If you look at the college curriculum gives you what all components are there in the common competencies. It's like 25 components, it says, that you need to know. However, most of these competencies are covered either in OSCEs or they are covered in your SJP. They can be covered in your management portfolio. So there are very limited topics which college would like us to know. These are the topics which college wants us to know: history taking, clinical examination, therapeutics, decision making, prioritization of patient, infection control, allowing patient to make self-care, health promotion, legal framework, and evidence and guidelines. 7 questions out of 60. That's around 13%. Now people will say, how will they ask me history question? How will they ask me physical exam question? Yes, they would like to keep it in OSCEs, your history taking, physical examination. However, they can present those things in the exam in a way like, if you remember the risk scoring systems or red flags of a particular diagnosis or a particular symptoms, then you will know what aspect of history is important. For example, if a patient has come with a bruise, it's a young child with a bruise, what aspects of history we are thinking about? He has a bruise. What could be the cause? Trauma. It could be accidental. It could be non-accidental. It could be any coagulopathies. This patient is not on any anticoagulants. He's a young child. So most likely it will be trauma, either accidental, non-accidental, coagulopathies, and one of our friends,
Sorry.
lymphoma, leukemia.
Okay.
So let's see how we are going to read the question. Is we're going to read the question, then we'll go to the STEM, and then we will answer. What 2 important aspects of history will be important before you decide to sedate him with ketamine and morphine? So you want to know history. Due to some reason, your consultant is unhappy for sedating him and asks you to perform an interscaling block. What part of physical examination is essential before you do the block? What necessary steps are essential before you initiate your procedure? It's common sense. You do it every day. Now let's read the question stem. 22-year-old is here with history of right shoulder dislocation after a fall. His pain has been addressed with oral paracetamol and codeine. You decide to go ahead with reduction of his shoulder and move him to Resus Bay. He has never had any medical problems, never been to a hospital for any issue. So that means no surgical problems as well. He has no allergies. What other aspects of history would you like to do before sedation? Now you need to think of ample. Allergies, medications, past illness, last meal, and events. 2 important aspects of history will be important before you decide to sedate him. He does not have any allergies. What are the risk factors for a anesthesia? What happens after anesthesia is patient wakes up from anesthesia. Patient complains of pain. Patient complains of vomiting. So what will put the patient at risk of post-operative nausea and vomiting? Male. No, females are more at risk. Non-smokers are more at risk. History of motion sickness are more at risk. Previous history of post-operative nausea, vomiting are more at risk. So sedation is something like anesthesia. So what aspect of history? Last meal, correct? And you want to know about his airway also. So you can ask history of dentition, you can ask history of any neck issues. Yeah. Due to some reason, consultant says no anesthesia, no sedation, you do a interscaling block. The answer is whether it is interscaling block, whether it is popliteal block, whether it is wrist block, whether it is ankle block, whether it is head, neck, face, toe block, whatever block it is. What aspect of examination is essential? When I go and do a facial echo block, what do I do?
Sensory motor examination.
Neurovascular, distal neurovascular examination. People don't think. People think, oh, I have to do the assessment of airway or I have to do, yeah. So distal neurovascular examination is essential before you block. What necessary steps are essential before you initiate the procedure? So I have prepared the medications. I have attached to the monitor. He's in research bay, so he's attached to monitor. Medications are prepared. So before you initiate the procedure, just before you initiate the procedure, what necessary steps?
Consent.
Okay, that's acceptable answer, because so consent of the patient, that's acceptable, and then you have done the neurovascular assessment as well, so that should not be written again over here. There's something called as stop before you block. Right patient, right side, right. So stop before you block is essential. History taking, we all know. We take history of current issues, onset, duration, progress, alleviating, aggravating factors, associated symptoms, past history, medication, allergies, family, social. Some people are comfortable with sample. The question in the exam is not formatted to assess your history. They are formatted for specific relationship to your diagnosis. If a patient is coming with a leg calf swelling or shortness of breath, and my diagnosis I'm thinking is pulmonary embolism, I want to know the history of oral contraceptive use, history of active cancer within last 6 months, history of recent fractures or immobilization, recent surgery. So like this they will ask. They don't want to test, okay, what history you want. NAI. If you're suspecting NAI, what history would you like to take? How many people live in the family? Is the parent still married, separated, single parent? Any drug use in the family, in the parents? Any other siblings? Any previous ED attendances? You will ask that. Thrombocytopenia patient, you will ask history of easy bruising, family history, asthma, asthmatic. Always you want to ask about recent ED attendances, previous ITU admissions, because these are mortality risk factors which will decide whether this patient can be sent home or not. How aggressive I can go. Clinical examination, they will again test better in your OSCEs. However, the questions are framed for theory purposes are ankle brachial index for vascular disease. So if somebody's come with a dislocated knee, I would like to do a ankle brachial index. Yeah. TIA risk in AF, you do the Chadwas. Some signs may be tested. Clinical examination signs. What is it? This is ecchymosis. Ecchymosis. Likely this is on the side of the body, right? So ecchymosis on the side of the body. What history would you want to ask for this patient? Whether this patient had met with a trauma, whether this patient is on anticoagulants, whether this patient suffers from lymphoma, leukemia. Ecchymosis around the umbilicus, ecchymosis on the side. If I tell he is alcoholic, he looks very unwell, severe tender pain in the abdomen, which radiates down to the back. Where am I going? Pancreatitis. So what is this sign called? What is this sign called?
One is great tunnels and Cullens.
Which one is Cullens and which one is
Columns is the umbilical one, great tunnels is the...
Yeah. So Cullens, CU, umbilicus, and when you ask the patient to turn on his side, he is Turner, the great Turner. Okay? So now this is communication. Okay? How do you communicate with the orthopedic SHO? What major aspects of history are important before you apply a back slab? What advice will you give to the patient about the plaster care? 36-year-old lady with fracture of right fibula at the ankle has been seen by your SHO. The orthopedic SHO is convinced that it is a stable fracture and just needs a back slab and a fracture clinic follow-up. He has been very rude to your SHO while discussing the X-ray with him. You have reviewed the images and are happy with the orthopedic SHO's plan. So how do you communicate with the orthopedic SHO? You have a duty to protect your SHO. You have a duty to be polite towards the other colleagues as well. Yes? So, and in fact, the orthopedic SHO's plan was correct. So, our SHO was wrong, but you can't just put him down. Politely apologize for inconvenience and ask him, why is he rude? So, what are the reasons for aggressive behavior or rudeness in the workplace?
Conflict.
There's a concept of doctor in difficulty. Doctor in difficulty. A doctor is difficult in the sense the doctor doesn't come on time every day. The doctor doesn't see many patients. The doctor is very lazy. He's running away early. He goes for 2 hours break. You can't just blame that this person is not good because he's like this. So we have such colleagues. We do come across such colleagues sometimes. Even sometimes we behave like that. What are the reasons? Not that we don't like to do our work. The reasons could be many. It could be personal reasons. It could be professional reasons. It could be system factors, isn't it? Maybe he is unwell and still he has to come because he can't change his nights. Maybe his wife is unwell. Maybe his kid is unwell. His father is unwell. Maybe the atmosphere at his home is not good. Maybe he failed in his exam. That's why he is least interested. You can't just say that he is lazy. You need to explore the causes. So, why is this person being rude? Maybe he came to work and there was nobody to support him. There was just one doctor alone and he has many patients. He's overrun. So what you will do is you will politely apologize for the inconvenience caused and you would say, is there anything I can help you with? Are you alright? Just saying this is a pleasant way to deal with anything, rather than just going and telling, you can't be rude to my SHO, you're just going to escalate the situation. But trying to figure out what's wrong with him, he might come and say, I'm alone doing my 4th shift now. What major aspects of history are important before you apply a back slab for this lady? Where are we going? We are going to do DVT risk assessment. Previous history of DVT. Any oral contraceptive use, smoking history, any history of any medical issues like antiphospholipid syndrome, SLE, that can put the patient at risk of developing a clot. Even occupation, because if she's working, then will she be able to manage the plaster at work? Will she need extended leave? What advice will you give to the patient about plaster care? There's a leaflet in the department. Keep the plaster dry. Non-weight bearing or weight bearing status. If you start getting pins and needles, tingling, numbness in your foot, distal extremity turns blue, please come back. You will be feeling itchy sensation due to irritation of the skin. These things are normal advices will you give. Therapeutics and safe prescribing. We have discussed this question of clarithromycin and quinolones with long QT interval and with CYP 450 inhibition. They will just beat around the bush for that. They can also ask about drugs which have narrow therapeutic index. The big one is lithium, digoxin, gentamicin, phenytoin, theophylline. You should know that these drugs are dangerous. These drugs have narrow therapeutic index. You need to monitor them. Yeah. So I can present a scenario with digoxin toxicity. I can present a scenario with lithium toxicity due to, okay, patient is on lithium for his manic disorder, and then he was admitted in the hospital 1 month ago with acute pulmonary edema, after which the doctor prescribed him furosemide. Now diuretic combined with lithium is not a good combination. He comes with altered sensorium and agitation, that's lithium toxicity. Vancomycin is having a narrow therapeutic index. One more thing is gentamicin will affect the kidneys. Second thing is gentamicin exacerbates myasthenic crisis. Yeah. Same thing with aspirin causes thyrotoxic crisis. Aspirin causes thyrotoxic crisis because it displaces thyroxine from thyroglobulin. So level of free thyroid increases. They might test you on the common antidotes. Warfarin toxicity antidote is if somebody's come with a intracranial bleed because some GP prescribed clarithromycin or quinolone or omeprazole and they came with intracranial bleeding, what two specialties would you discuss the patient with?
Hematology and neurosurgery.
Absolutely. So people remember neurosurgery, people don't remember that we have to discuss with hematology. We have to discuss with hematology. Immediate antidote for warfarin is
Vitamin K.
Vitamin K. Vitamin K inhibits epoxide reductase or factor 2, 7, 9, 10, which are vitamin K dependent factors synthesis. However, you also have to give a prothrombin complex concentrate. Yeah, it is called, the newer one is called as Octaplex. It's same stuff. Yeah, prothrombin complex concentrate. If that's not there, you can give fresh frozen plasma. Warfarin is the main pathway, so factor 7, not the alternative pathway. So you measure the PT, not PTT. Yeah, dabigatran, tran, anything with TR, dabigatran, argatroban. This is direct thrombin inhibitor, tran thrombin inhibitor. Yeah, direct thrombin inhibitor. It is used for many things. How would you treat this? You give an antidote to dabigatran. What is the antidote? Idarucizumab. Yeah, idarucizumab. This is the antidote. Yeah. So the other one is edoxaban, rivaroxaban, apixaban, xaban. That is factor 10A. If you look at it this way, dabigatran is direct thrombin inhibitor. edoxaban is factor 10A inhibitor. Okay. The antidote for edoxaban is, or rivaroxaban is, andexanet alpha. Always remember, whenever somebody is on warfarin, dabigatran, edoxaban, involve hematology. Time and workload management will be discussed in management portfolio and SJT. They will not ask about it in the exam. Again, clinical reasoning is patient as central focus of care and patient safety issues. When can be patient unsafe?
Violence?
So patient can be unsafe because of system factors. System factors, provider factors and patient factors. Yeah? Patient is really unwell. Extremes of age. These are patient factors. Mental state change. Complex condition, language barrier. Patient can be unsafe if there is a language barrier. Provider factor, provider is tired, fatigued. That's why we keep on telling you, go for your break, go for your break. It's not that we want to get you off the floor, it's that you need a break after 4 hours. Then overcrowding is the system factor. Lack of equipment, lack of resources, exit block. That is one thing. Do we know what is exit block?
When the wards are full and you don't have a bed to move the patient from
Yes.
the emergency.
So when we don't have when there is a block for the exit out of the ED, it's called exit block. What is an S-bar approach to communication? How do you refer your patients?
Introduce ourselves.
Yes. Then
I tell about the word patient.
so you tell about the situation. I have a 80-year-old who's come with a history of fall. He suffers from this problem. You give the background. Then you say what your assessment findings are, and then you provide your recommendation. My recommendation is this patient needs to come in and get admitted, or needs further evaluation, so it needs to be coming in the hospital. What is the organism implicated from the likely source of sepsis? What is the likely cause of his diarrhea? What transmission-based precautions are recommended? 39-year-old male is admitted to A&E with high-grade fever, diarrhea and discharged from surgical wound site. He was released from the hospital 5 days ago after an IND of an abscess on his thigh. He had 3 IND surgeries at different sites in the last 2 years. No other comorbidities. See, person is getting multiple abscesses, 3 surgeries in the past, in 2 years. Now again he's drained. What is the likely organism to cause an abscess?
In his case, it would be
Staph aureus.
Staphylococcus aureus. And in his case, it is recurrent, so it is methicillin resistant
MRSA.
Staph aureus, MRSA. So, organism here is methicillin resistant Staph aureus. What is the cause of his diarrhea?
He must have received recurrent antibiotics.
oral antibiotic.
So, antibiotic induced diarrhea, likely it is secondary to either coamoxiclav, or if the doctor has been smart enough and thought, oh, this is MRSA, so I'm going to start him on clindamycin.
Clostridium difficile.
Clostridium difficile. So if Clostridium difficile diarrhea is there, what transmission-based precaution methods are used? What are the 3 methods of precautions? Apart from standard precautions, what are the 3 methods? One is contact precaution.
Yes, isolation.
Second is droplet precaution. And third is airborne precaution. Now tell me, which patients will get contact precautions?
Contact will be on measles.
C. diff. C. diff gets contact precautions. Yeah. MRSA gets contact precautions. Viral hemorrhagic fever gets contact precautions. And droplet precautions.
Airborne.
Airborne is another precaution. Droplet precaution. Neisseria meningitidis, droplet precaution. Mumps, measles, mumps. Yeah. See, what is a droplet? A droplet is a thick droplet. If somebody spits out or sneezes out or breathes, it's going to fall just here. Airborne is fine particles. It can go up to anywhere in this room. That's airborne precaution. So droplet precaution is somebody who's pretty close. And mumps is, by the name itself, it's chubby. So mumps and measles is droplet, and Neisseria meningitidis. Who gets chemoprophylaxis in Neisseria meningitidis? If you have seen a patient of Neisseria meningitis, do you get chemoprophylaxis?
No, probably if he's traveled elsewhere.
Unless, if you see a patient, you don't get that. Unless you were involved in his airway management. Because it's a droplet. By examining a patient from a distance, you will not get. But if you were involved in airway management, you get prophylaxis. Prophylaxis is with rifampicin or ciprofloxacin. So contact precautions: MRSA, C. diff, scabies. Droplet precaution: Neisseria meningitidis, mumps, rubella. Airborne is chickenpox, TB, measles. Sorry, I told measles here, but measles is here, but mumps and rubella is here. Normal hand hygiene, routine hand wash with alcohol rub before and after every patient contact. Yeah. Antiseptic hand wash using chlorhexidine and alcohol for every invasive wound care procedure. So before cannulation, please do that. A surgical hand wash for surgical procedure. Diarrhea, you will do standard precaution plus contact precaution. So diarrhea, isolate with contact precaution. MRSA, isolate, contact precaution. The patient is deemed MRSA negative after 3 consecutive negative screens. So 3 times when you screen them, then only they should, if they are negative, and it should be consecutive. Sharps. If you get a sharp injury, let it bleed, wash it with soap and water, and do not carry sharp in hand like this, yeah, to reduce the sharp injury. And always stick to the needle stick policy and fill up the incident form. We'll pause over here.